Thank you, APAS. Comparative study of early functional outcome between CR knee and 3D knee. Who is more satisfied? The goal of total knee arthroplasty is to relieve pain and ideally to regain individual tibiofemoral kinematics. However, patient satisfaction after TKA ranges between 70% to 90%, which might be associated with different available implant designs. Numerous prostheses have been developed to improve the durability and function of these total knee arthroplasties. And CR knees have good preservation of the bone, more normal knee kinematics, increased proprioception, better femoral rollback on tibia during flexion, and greater stabilization of the prosthesis. More recently, the 3D kinematic knees developed with lateral pivoted extension and medial pivot inflection, aiming to provide inherent anteroposterior knee stability and recreates the motion pattern of natural knee. So what is the need of this study? To assess and compare the patient satisfaction between CR knee and 3D knee patients and establish the difference in clinical outcome, if any. This study is done to compare the early outcome of CR knee and 3D knee with respect to postoperative knee range of movement, pain, and patient satisfaction. There are rarely any published articles regarding clinical outcome of 3D knee. Few articles do support the concept of lateral center of rotation in total knee arthroplasty to restore the normal joint kinematics. These are the few papers who shows that the arthroplasty design had ability to restore the individual joint kinematics, though the center of rotation is altered. Few papers, they also say that the center of rotation is predominantly on the lateral side of the knee during walking, and normal function of the knee during walking is associated with both lateral and medial pivoting. So in our study, total 40 patients included, 20 in CR knee and 20 in 3D knee group between June 16 to June 17, and all patients followed up every month and knee society score calculated till first year post-surgery. The principal questions related to satisfaction consisted of asking the patient regarding overall function of the knee, the ability to perform normal activities of daily living, satisfaction with a degree of pain relief. The principal questions related to symptoms inquired about the presence of any pain or stiffness in the knee joint, audible noises in the knee joint including popping, clicking, or grinding sounds, and experiencing any swelling or sense of tightness in the knee joint. And to assess the function, the patient was asked about the ability to get in and out of the car, getting in and out of the chair, going up and down the stairs, and the presence of any limp, and whether their knee felt normal. It is a single center, single surgeon, and same protocol study, and patients were discharged on day 4 with full weight bearing walking with walker, knee exercises, commode training, and suture removal was done on 15th day. Inclusion criteria: all the patients above 60 years of the age, moderate to severe knee pain which disturbs the daily routine activities, patients with tricompartmental osteoarthritis knee with less than grade 3 varus deformity and up to 10 degrees of fixed flexion deformities. And exclusion criteria is patients more than 80 years old age, inflammatory arthritis, valgus knee, Charcot joint, previous surgery, infection, severe comorbid conditions, or severe varus more than grade 4 or FFD more than 20 degrees which require additional stem support. So in our observation, patients in both the groups were comparable in respect to age, sex, preoperative range of movement, and deformities. These are the few cases with CR knees, PCL is intact, and these are the cases with 3D knees. The 3D knee patients, they show more range of movement, less pain, and knee society score as compared to CR knee during initial 3 months. But as we proceed, the patient satisfaction is better in initial 3 months in 3D group, but at the end of 1 year, there is no significant difference in range of movement, pain, and patient satisfaction in both the groups. So the clinical success of TKA is partially dependent upon total knee arthroplasty design with suitable congruity and constraint to provide adequate knee joint stability throughout the full range of motion. And the articular design with progressive congruency in lateral compartment can provide femoral condyle rollback in maximal flexion activities and good clinical outcome at midterm follow-up. In conclusion, both the groups, they show similar and good functional outcome at the end of 1 year, though 3D group showed better score during early post-operative period. Our limitation is small sample size and long-term follow-up is not available. Thank you.